Well, welcome everyone to the EKG case for the week of December 3rd, 2012. This is Mattu at University of Maryland. And, I just want to say I love the T-wave. It's not like a crush or anything like that, but I love the T-wave. And the reason I love the T-wave is because, in general, I love the underdog. And the T-wave is really one of the underdogs of the EKG. Certainly the underdog of the P-QRS-T complex. Everybody pays attention to the P-wave and the PR interval because you need that to figure out what somebody's rhythm is, AV blocks and such. People pay a lot of attention to the QRS complex because it's important to figure out whether it's wide or narrow, VTAC or SVT, whatever. People pay a lot of attention to the QT interval, but people pay very little attention to the T-wave. The T-wave, it's just, it's the repolarization. Nobody really cares about repolarization. People care about depolarization. The T-wave is very important. It is the underdog, and as a testament to the fact that I love the underdog, I love the lead AVR as well for the very same reason. Well, this week we're going to talk about two great cases where the T-wave became the hero, and the physicians that picked up the T-wave abnormality were really the heroes also. This first case was sent by Dr. Sanjeewa Kulawikrama, and I will admit, honestly, I had to practice that name just a bit, but when Dr. Kulawikrama sent the email, he abbreviated the name Sanj, and so hopefully I can just abbreviate that name, Sanj. But anyways, taking care of a 64-year-old man with mild chest pain, and the patient's pain was very mild, 1 out of 10 intensity, mild central chest pain and some concerning right arm heaviness. Patient has a history of smoking. Of course, you start with the 12-lead EKG. I suppose you can do a history in there somewhere as well, but you got to start with the EKG. And there were some concerns that Sanjeewa saw on this 12-lead. That the EKG machine, by the way, does not necessarily pick these type of things up. First of all, there's what we would call J-point elevation. Oh, let me change the color there. There's a little bit of J-point elevation in V1, V2, V3. And is that benign J-point elevation or is that concerning? Well, there's a couple of things that may make you a bit less concerned about that J-point or ST segment elevation, in that the beginning part of the T-wave is concave upwards. If it were oblique or if it's convex, you're definitely going to worry about it. Also, in males, in the right precordial leads, this tends to be a little bit more common. And so, well, maybe we'll come back to that. A couple other things that we're seeing on the 12 lead. There's just a little bit of ST depression in a few of these leads, the inferior and lateral leads. And again, the EKG machine is not going to pick that up. At most, your machine will call that non-specific ST or T-wave abnormality because it's less than a millimeter in depth. But Sanjeewa was concerned enough about that and remembered a previous podcast where a really smart guy by the name of Corey Slovis made a comment that one ECG begets another, and Sanjeewa actually put that in the email that was sent to me. One EKG or ECG begets another. So Dr. Kulawikrama went ahead and got another, and of course, when in doubt, I always say, when in doubt, get serial ECGs, but doesn't quite sound so eloquent the way Corey Slovis's comment does. So go forward, get another 12-lead EKG 10 minutes later, and here's what you got. It's not really changed much. You've still got that little ST depression in a few of the leads, and you still have that little J-point elevation up there. Well, they went ahead and gave the patient a sublingual nitroglycerin. Pain goes away, all right? It went from a 1 out of 10 to a 0 out of 10. So what do? Do you need to do anything? Well, whenever the symptoms change, you get another 12-lead EKG, even if that symptom change is pain resolution. So repeat 12-lead EKG is done. And now what Sanjeewa picks up is, take a look at the T-wave. There's just a little bit, a subtle terminal T-wave inversion, especially up there in V2 and V3. Now, again, your EKG machine is not going to pick that up, but Sanjeewa did and was very concerned, and perhaps was thinking back to March 25th, where we talked about the possibility of early Wellens waves. And for those people out there that may not know what Wellens waves or Wellens syndrome is, go back and take a look at the video from March 25th where he talked about Wellens. And this was one of the cases. This patient came in with This is the baseline 12-lead EKG, so this is baseline. No big deal here. Everything looks good. But then when the patient developed problems and came to the emergency department, the patient developed very similar, just very, very mild terminal T-wave inversions. At the end of the T-waves, the T-wave just flips just a little bit. We'll put those two side by side. So here's the baseline, and here's what the patient has now. And you can see that the T-waves have gone from nice and happy like that to, well, just a little bit of a frown at the end of the T-wave, and I'm exaggerating it with my drawing because I stink at drawing, but I think you can appreciate that there's just that little bit of terminal T-wave inversion that you see right at the end of that T-wave. I guess that's what terminal T-wave inversion means, and that's an early marker. And what ended up happening with this patient went on to have a big anterior MI and went for a cath later in the day. So that's what Sanjeewa was worried about, I think, when looking at this. So he called up the local cardiologist who was 30 minutes away and said, I'm really worried about this patient. I put discussion here in quotes because, Sanjeewa had to kind of push to get this cardiologist to accept the patient. Finally, the cardiologist relented and took the patient 30 minutes away, and the patient ended up having a 95% LAD lesion predicted based on that early Wellens T-wave. Troponins were positive, and Dr. Kula Wickrama has saved a life. So high five goes to Sanjeewa. By the way, I don't know who these two people are, but I found them on Google Image when I did a Google Image search for high five. So if anyone knows who these two people are, send me an email and I'll send them a little thank you note for participating in the EKG video series. All right. So great job, Dr. Kula Wickrama. There is a life saved by paying attention to the T-wave. Very subtle abnormality on the T-wave that your machine will not detect. And the other important point is when the patient's very mild, nothing kind of pain changed, in other words, the pain went away, Sanjeewa went ahead and got a repeat 12-lead EKG. Remember, when in doubt, get another EKG or ECG or whatever you call it. Get another one. And you may be surprised at what you see. That's very important. Next case was sent by Dr. Mohammed Abraham, who works in Milton, Canada. This was another very atypical, very nothing kind of chest pain. And when I say nothing kind of chest pain, I just mean it wasn't impressive at all. 65-year-old. He works out every day. And this particular day, he did a bench press workout. He worked his pectoral muscles quite a bit. And he thinks maybe he overdid it today. He's got a history of hypertension, but it's so mild his doctor has not put him on medication. So a really healthy guy who comes in saying, I think I overdid it. Well, he went home after his gym workout and experienced this 2 out of 10 retrosternal chest pain. There was no radiation, no sweats, no vomiting, no palpitations, none of the major concerns that we have. Normal exam. And you know what? If he's got muscular pain, that normal exam was a bit of a red flag to Dr. Abraham because he thought, if this is just muscular chest pain, it probably ought not to be a normal exam. Maybe you should at least have some reproducible chest wall tenderness, but it wasn't there. The guy's just sitting there joking around. No big deal. He's munching on some Cheetos or something. He's not looking sick at all. But what do? You get a 12-lead EKG. Here's the initial 12-lead EKG, which concerned Dr. Abraham. Once again, the computer calls this unremarkable. Your EKG machine's not going to pick this up. So a couple of abnormalities jump out at you. First of all, there's some smudges on the 12-lead, but we'll get rid of that. There's a couple of subtle T-wave abnormalities here. Take a look at leads V3 and V4. When you look at the beginning part of the T-wave, normally we want to see the beginning part of the T-wave concave upwards like this. But in this particular case, it's very straight. It's almost tombstone-y in appearance. And we've talked multiple times on these EKG video series about the importance of recognizing when the initial part of that T-wave is very straight like that. We're a little bit happier about that. We're certainly happier about this. And we're not going to worry about this occurring in V1. V1, for whatever reason, can produce all kinds of T-wave abnormalities. The initial part of the T-wave can be concave, straight, or convex in V1. But when you see that in any of your other precordial leads or in your limb leads, you've got to worry about that straight. And I'm going to draw it over and over so you get accustomed to that appearance. when you see that the initial part of that T wave is very straight, it doesn't mean they need to go for a cath, but it means that you need to repeat the 12 lead. Remember, one ECG begets another. Repeat that 12 lead and look for something to evolve. And the machine's not picking that up because there's no overt ST segment elevation. Anyway, repeat 12 lead was done a short time later when the patient's pain resolved. And what do you know? Something has changed. We'll take a look at V3 and V4. Remember, it was straight before. Now you can see it's a bit more concave upwards. So it has changed now that the patient's pain has resolved. Let me go back. Here's when the patient had very mild pain. You see how straight that is? And now the patient's pain's gone away, and you can appreciate that the patient's ST, the beginning part of that T wave, is more concave upwards. That is a significant change. If you're using the same lead placement, the same EKG machine, that subtle abnormality was significant enough. So we went ahead and sent off some troponins. First one was positive. The next troponin doubled. And the patient was initially treated medically because he did actually develop overt ST elevation. The patient was aggressively treated medically, and then a number of hours later, now you can see that the patient has developed Q waves in V1 and V2. The patient ended up doing well with aggressive medical treatment in this particular case. So we'll summarize this again. The take-home point. Number one, when in doubt, get serial ECGs. Remember what Corey Slova says, one ECG begets another. I'm going to take that a step further and not even say begets another. I'm just going to say get serial ECGs. Maybe not one more, but maybe 2, 3, 4 more. Don't be afraid to get serial ECGs. Remember, it's a piece of paper and ink. It's cheap. It doesn't cost much of anything, but it can give you life-saving information. Number two, repeat the ECG whenever the patient's symptoms change. Everybody repeats ECGs when people go from no pain to having pain. Well, it's important to also repeat that ECG when they go from pain to no pain. In other words, when the patient's pain resolves, that is a change in symptoms as well. So when their pain resolves, repeat the 12 lead. And in both of these cases, because the ECGs were repeated, when the pain resolved, fairly atypical and mild-sounding chest pain suddenly became notable as concerning because the ECG changed. And then number three, I didn't put number 3 in here, but I'm just going to write that in. Pay attention to the T wave. It is the Rodney Dangerfield part of the ECG. Rodney Dangerfield, famous comedian who never got any respect. T waves deserve your respect. They can give you life-saving information. Pay attention to the T wave. We've talked a lot about T waves in this EKG video series, and hopefully people are paying more attention to morphologies with the T waves. T waves can save lives. All right, so pay attention to the T wave. All right, well, I hope that was helpful. 2 great cases. My thanks to both physicians that sent in those cases, and I will talk to you next week. Bye for now.